Hello everyone, today I'm going to talk to you about my capstone project in Genentech's US Medical Affairs Group. It was entitled A Retrospective Analysis Comparing Patients with Diabetic Retinopathy with patients with to patients with diabetic retinopathy without diabetic macular edema in Truven market scan claims and Medicare supplemental databases. The purpose of this project was to study ranibizumab, which is Lucentis. At the moment, it's currently indicated for the treatment of patients with diabetic retinopathy without DME. The ranibizumab team is asking for a filing a supplemental biologics license agreement to the FDA to gain approval for DR patients without diabetic macular edema. To supplement it, they've requested a comparison of those two different cohorts, DR with DME and without DME. Therefore, we've been tasked with creating a non-interventional study, which involves a retrospective database analysis of these two different cohorts using Truven market scan, commercial claims, and Medicare supplemental databases. The primary objective of this study is to compare the Charlson Comorbidity Index, CCI, between DR patients with and without DME. The Charlson Comorbidity Index utilizes ICD-9 codes that are in medical claims to create an index score for each patient over a 1-year period of time, and that comorbidity score allows for a 1-year mortality predictive to predict a 1-year mortality. Essentially, a score from 0 to 2 is a fairly healthy patient. A score from 2 to 6 and above is usually a much sicker patient population. The design, this is a retrospective database analysis utilizing US patients with diabetic retinopathy, the two cohorts being with and without diabetic macular edema. There are a number of variables that we studied, and we pulled data from two different databases. The study size, which I'll talk about in a little bit, involved a convenience sample from those two databases, and for feasibility's sake, we did power calculations to determine 20,000 patients per arm was sufficient for the two cohorts. And then as far as data analysis for categorical variables, we used a chi-squared test, and for continuous variables, a t-test was utilized. For the power size calculations I spoke to earlier, to detect the mean detectable difference in the CCI, Charlson Comorbidity Index, for a two-sample t-test was found based on the inflection point of the SAS output here, which was around 20,000 per arm. For the categorical, a person chi-squared test was used, and again, we see the inflection point around 20,000 at each of these points. This was for a cutoff of for two different categories, 0 to 6 and 6 and above, to denote a really sick population from a fairly healthy population. Inclusion and exclusion criteria. These are the ICD-9 codes that were used to determine the two different cohorts. The DR with DME cohort inclusion criteria involved having one of these two a code of 362.07 along with one of the other DR codes, 362.01 through 362.06. And for without, it was 2 occurrences of DR codes within 365 days of one another, as well as no treatment of an anti-VEGF vascular endothelial growth factor, which includes ranibizumab, so prior treatment with our drug had not occurred within that 365-day span. The results, the two cohorts of patients that were identified in these two medical claims databases from January 2007 through first quarter of March 2013. Again, that coincides with when Lucentis was commercially available. It yielded around 40,000 DR patients with DME and 45,000 patients with DR without DME. These two cohorts were similar with respect to age, but when it came to patients' age, they were same with respect to sex, but when it came to age, DR patients were older than DME and had a higher CCI score, a slightly higher CCI score, though it was statistically significantly different. Also, DME patients were identified as having 2 or more Charlson comorbidity-related or Charlson-related comorbidities as compared to those with diabetic retinopathy alone. And that can be seen in this table. So again, there isn't a big difference in age or in sex between the two different groups, DME and then DR without DME. But when it came to age, different age categories as well. And then for the mean CCI and for the number of Charlson comorbidities, again broken up categorically 0 to 2 or 0 to 1 and then 2 or more. It was seen that they were statistically significantly different from one another. Discussion of results. So what does this mean? It suggests that patients in the MarketScan as well as Medicare databases with DME are similar to patients with DR without DME with respect to sex, but patients with DME are slightly older. They have significantly higher levels of comorbidities as determined by the CCI and represent a sicker patient population than patients with DR who do not have DME. As far as limitations, medical claims are obviously not intended for research, and so therefore they have a number of innate limitations. Also, a lot of the different conditions related to the comorbidities captured in these medical claims may not be sufficiently captured by physicians and therefore may underscore a CCI index output that may be actually more inflated than what is seen. We also did a large convenience sample. Since it's not random, there could be biases, as well as the fact that Medicare supplemental databases tend to profile higher socioeconomic statuses, which may not indicate the entire patient population receiving a drug related to diabetes. And again, CCI figures due to underreporting in ICD-9 diagnosis codes could lead to skewed data or an overestimate of the burden of disease. And with that, I'll thank you all. Here's some references. I look forward to your feedback.